Class number 6. Echocardiography Introduction. The main components of the human cardiovascular system are the heart, blood, and blood vessels.
Cardiac output is a very important concept because it measures the capacity of the heart to pump the quantity of blood that the body needs. The units are volume units, and the most common used are liters. The human body constantly changes the cardiac output to pump more or less blood depending on the situation. To increase cardiac output, the heart can increase the stroke volume. Stroke volume is the volume of blood pumped from one ventricle of the heart with each contraction. The heart also can increase the number of beats by minute. The average resting cardiac output is around 5 liters by minute.
This graphic explains the relations between pressures in the left ventricle, the aortic artery, and the left atrium synchronically with the volumes in the left atrium, the electrocardiogram, and the cardiac sounds. The cardiac cycle is divided in 7 phases, 3 in systole and 4 in diastole. The first phase is the atrial contraction, and begins with the P wave of the electrocardiogram. The letter A marks the atrial contraction with the little raise of left atrium pressure just before of the ventricular systole. As the atria contract, blood flow across the open mitral and tricuspid valve, adding more blood to the ventricles. Atrial contraction normally accounts for only about 10% of the ventricle blood volume. 90% of the blood in the ventricle enters before the atrial contraction. The phase number 2 is called isovolumetric contraction, and begins with the QRS electrocardiogram wave. Other important mark at the begin of this phase is the mitral and tricuspid valve closing. The first sound of the heart is the closure of the mitral and tricuspid valves. At this phase, ventricular pressure increases rapidly, but the volume remains the same because the aortic valve has not been opened yet. Number 3 phase begins when the aortic valve and the pulmonary valve opens and blood of the left ventricle and right ventricle respectively enter into the aorta and pulmonary artery. This phase begins when the aortic pressure is more than the left ventricular pressure, and finish when the aortic pressure is equal than the left ventricular pressure. In this phase, even the pressures in the ventricle and aorta are equal. Blood continued entering in the aorta due to inertial energy. Isovolumetric relaxation, or phase 5, begins when the aortic valve and the pulmonary valve close, causing the second heart sound. As in phase 2, phase 5, the volume remains the same in the ventricle, but contrary, the pressure does not increase. In phase 5, the pressure in the ventricle decreases very fast. The heart normally do not pump all the blood in each contraction. The volume that remain inside is called end diastolic volume. When there is a systolic dysfunction, the end diastolic volume is big, and the ejection fraction is less than 50%. Phase 6 begins when the mitral valve opens and the left ventricle begins to fill. At this phase, 90% of the ventricular blood enters in the ventricle. In the spectral Doppler of the mitral valve, the first rise corresponds to phase 6, and the second rise to phase 1 of the next cardiac cycle, or atrial contraction. The last phase, or phase 7, is called slow filling, and is among the rapid entry of blood and atrial contraction. Stroke volume is directly proportional to the filling pressure of the ventricles. More blood enters in the ventricle, more blood ventricle pumps. When more blood enters, the muscle wall stretches and shrinks more harder. Echocardiography uses conventional ultrasound and combined two-dimensional, 2D, Doppler approaches to measure mathematically important cardiac physiology such as cardiac output and ejection fraction. The Frank Starling explains minor changes in cardiac output, but if required and may or increased in cardiac output, the number of beats per minute should also increase. This table summarizes the most important structures of the heart with the main echocardiographic views. The windows and views are represented by icons and initials. Each cardiac structure is aligned with their view. The first of the 2 principal windows is the peristernal window. It is at left of the sternum bone, around the 3rd or 4th intercostal space. The position of the parasternal window varies with each patient and sometimes also to visualize different structures in the same view.
Parasternal long-axis view is a sagittal view of the heart that shows the left-sided chambers, mitral valve, aortic valve, a little part of the right ventricle, and the proximal aorta. PLAX is commonly the first view of a cardiac ultrasound study.
Left atrium, right ventricle, left ventricle, aortic valve, mitral valve, ventricular septum, pericardium are the cardiac structures of this table that you can see in parasternal long-axis view.
Case when you're cutting off the aorta and the ventricle, that a twist can really help you find the best window or improve your window that you've already found. Now in this particular case,
take a look at the parasternal long-axis view of the heart in action. Remember again that the most superficial chamber will be the right ventricle, and the normal dimensions of the right ventricle are that it should be about half the size of the left ventricle. If the right ventricle is the same size of the left ventricle, that could be a sign of RV strain. We see the left ventricle posterior to the right ventricle. Note its hypertrophic walls. This patient actually had long-standing hypertension. Let's look at the percentage change from diastole through systole, and here we see that the walls come in well with each heartbeat, indicating good contractility. We see the left atrium to the right of the left ventricle, and notice the mitral valve flipping up and down in between the left atrium and the left ventricle. We see here good movement of the mitral valve, indicating a good amount of blood flowing between the left atrium and the left ventricle. Now just above the left atrium and to the right of the left ventricle, we see the aortic valve, and notice there, just to the right of the aortic valve, a little bit of the diamond-shaped aortic root. This will be our left ventricular outflow tract. Now another very important structure to identify on bedside sonography is the descending aorta, which is a cylinder cut in cross-section right below the mitral valve as seen in this image. This is a very important landmark because the posterior pericardial reflection, that white line seen posterior to the left ventricle, comes off anterior to the descending aorta. This allows us to tell if the fluid that we see there may be pericardial or pleural.
In the parasternal long-axis viewpoint, the orientation marked to the right shoulder. Try moving the transducer to achieve the optimum position. The optimum position is different in each patient. The optimal image cuts through the middle of mitral and aortic valves to display left ventricular inflow and outflow. The view is better when the septum is perpendicular to the transducer and at the same level of the aorta. Ascending aorta should be a tube.
Sometimes not all structures can be aligned in a single view. In this situation, record several views focused on each detail.
All you can record in this view is important, but spectral Doppler is not accurate because the perpendicular direction of the blood flow. The parasternal long-axis view provides a reliable picture of the function of the basilar portions of the anterior septum and posterior walls. Blood flow in this view is almost perpendicular to the ultrasound, and even colored Doppler give important information. The exact velocity of the blood is better recorded in apical views. M mode is very useful in the parasternal long-axis view because the perpendicular orientation of walls and valves, diameters of the septum, left ventricular wall, left ventricular cavity, in diastole and systole, aortic valve, left atrium, and other important measures can be taken in this view. The advantage of the parasagittal view is that the left ventricular walls are perpendicular to the ultrasound and optimize the quality of the images in B mode. Wall thickness, contraction, the ventricular volumes, ejection fraction are the best in this view. The picture shows the measurement of ejection fraction with M mode. The orientation of this view is excellent to measure the left ventricle outflow tract. Although the blood moves in a direction perpendicular to ultrasound in the parasternal long axis, color Doppler produces, with enough quality, diagnostic images of regurgitation. In the two left heart valves, in the parasternal long axis, the area of the right ventricular cavity, you see, is the RVOT, right ventricular outflow tract, the hyperechoic structure that surrounds the heart. In other words, the pericardium can be seen in all echocardiographic views. The crucial diagnosis of pericarditis can be obtained in multiple views, as in the parasternal long axis. The transverse views to the heart are called PSAX, or parasternal short axis views. They are the aortic valve view at the top, the mitral valve view at the middle, and ventricular view at the bottom. All of the cardiac structures in the table can be observed in parasternal short axis views. Note in the table a icon, as a Mercedes-Benz sign is the aortic view, a mouth represent the mitral view, and a mushroom represent the ventricular view.
Short axis view, because you won't be seeing the chambers that you expect you should be seeing. So in this case, here we have a perfect mitral valve. The best place to check for how round you are is with the mitral leaflets. So we can see both leaflets across. They're horizontal across the screen more or less, and they're completely parallel to one another. Now if I'm not...
The parasternal short axis aortic view is very important because near of all the structures of the heart can be observed with the exception of the left ventricle, the interventricular septum, and the mitral valve. Near all the principal structures of the heart can be seen in parasternal short axis aortic view. Right atrium, left atrium, aortic valve, pulmonary valve, tricuspid valve, pericardium. The parasternal short axis mitral valve view is an excellent view of the valve in a transverse position. Otherwise blood flow is perpendicular and Doppler is limited, but helpful in this view. In this view can also be the right ventricle, but the most important is the observation of the mitral valve in a parallel plane. Parasternal short axis ventricular view is good to measure septum and walls of the left ventricle, and also can be used to calculate ejection fraction. Right ventricle, left ventricle, ventricular septum, and pericardium are the cardiac structures in this view. The sectional view of the left ventricle with the two papillary muscle outline the typical mushroom shape. For parasternal long axis rotate 90 degrees the orientation mark of the transducer and point to the left shoulder. Try to keep the aortic valve in the center, and rotate until you can see the transverse view the aortic valve called the Mercedes-Benz. In the parasternal short axis aortic view only left ventricle, mitral valve, and ventricular septum cannot be observed. All the other cardiac structures of the table can be seen. Rotate and rock the transducer until the aortic valve appears round and in the center of the image. Left atrium, interatrial septum, right atrium, the tricuspid valve, the right ventricle, and the pulmonary and aortic valves are the cardiac structures that are easy to observe in this view. Optimal image should have a round aortic valve with 3 cusps. And the tricuspid valve should be visible on the left side of the image, and the pulmonary valve on the right. Doppler and color Doppler of the tricuspid and pulmonary valve are good, but spectral Doppler of the aorta is not accurate because blood flow is perpendicular to the ultrasound beam. The image shows the color Doppler of the pulmonary artery. Pulmonary artery is a structure that only can be observed in this view. If you're using the principal windows, the image shows a spectral Doppler of a pulmonary regurgitation. It is very good because blood flow is parallel to the ultrasound beam. Aortic valve must be in the center, showing all the 3 cups. Left coronary cup on right side of the image. Right cup at the top of the image. And non-coronary cup on the left of the image. This is the typical view of the aortic valve in systole, with all the 3 cups open showing a triangle shape. You can see the right ventricular outflow tract around the aorta. You can see the tricuspid valve at left of the aorta. PSAX. Aortic view is excellent for pulmonary regurgitation. Left atrium is posterior to the aorta. Interatrial septum also can be observed in the four-chamber view. It is not a structure very important in adult. Most common cardiac diseases is more related with congenital problems. This view is important in the study of the mitral valve, but have no use in the study of other cardiac structures. Blood flow is perpendicular, but color Doppler is generally recorded. Rock the transducer a little to the lateral inferior direction. It is a very little movement. If you move too much, you can lose all the parasternal view. Planimetry is a procedure to measure the area of the mitral valve when there are stenosis. Sachs mitral view is not the best. Apical 4 chambers is better. The image shows the anatomy of the mitral valve and a three-dimensional image of the valve in the same plane as Sachs mitral view. Right ventricle, left ventricle, ventricular septum, pericardium are the cardiac structures in Sachs ventricular view. Rock the transducer slightly more towards apex. This is the classic mushroom view. This view can be an alternative for parasternal long-axis view to calculate ejection fraction in myocardium walls. This view is very good in real time to study conduction problems. A lot of sonographers prefer this view to calculate ejection fraction. The left ventricle is the most massive structure of the hearth, and a majority of the hearth pathologies are about the function of the left ventricle. This view is an orthogonal plane with the parasternal long-axis view, and add more valuable information to the left ventricular study.
Plane, and note the muscular contractions of the left ventricle as a cylinder squeezing in dramatically during systole. We also note the mitral valve flipping up and down within the left ventricle, and the right ventricle as seen up and above the left ventricle. Now let's contrast this video clip showing excellent contractility with another patient who had an advanced cardiomyopathy. Note again the left ventricle, and note here the poor percentage change from diastole through systole, indicating an advanced cardiomyopathy with low ejection fraction. We can also see the right ventricle anterior to the left ventricle. For learning purposes, we'll identify the walls of the LV, the septum in between the ventricles, the anterior wall to the top of the screen, posterior wall to the back, and the lateral wall as shown here towards the right portion of the screen. Now while I show the walls,
This view can make same calculations as plaques. In special pathological conditions as constrictive pericarditis, this view shows the right ventricle typical collapse. Apical window with parasternal windows are the most common used windows in echo. Other window as subcostal and suprasternal window are used more for complementary information or as specific pathologies diagnostics. Commonly the only structure which is not observed from the apical views is the pulmonary valve. It is worth to add that the flow of blood direction and the views of this window are very suitable for both color and spectral Doppler as well as continuous Doppler.
To make the circle smaller in the area where I'm closing in on it, and if I pass, I can just back up on the circle and then I can fall back into my view. So again, by circling around, see how big the movements are, very gross with my hand, and you can see what's changing on the screen as well. Just back up a little bit after I've passed something that's bright and then go into the nicer view, and now I can make my more minute manipulations to get and fine-tune an image. But it's very easy to end up in a place where you're working, and it's not a good window, and if you just take a little circle survey or go window shopping, you may stumble into a better view. But if you're
Apical 4 chambers view is one of the best views in echocardiography. This view provides the study of the hearth with a lot of anatomical and physiological information, and is an essential part of any ultrasound hearth protocol. Only the aortic valve and the pulmonary valve of the cardiac structures in the table are not seen in the 4 chambers view. The orientation mark of the transducer must point the couch. Optimal image of 4 chamber view depend a lot of the position of the transducer. It must be as near of the apex of the hearth as is possible. Optimization of the views always depends on the final movement of the transducer. Taking into account also the personal and medical characteristics of each patient are multiple possibilities to increase the amount and quality of sonographic information, depending on the skills of the operator. Optimal image should be at apex with both ventricles, both atria, and both mitral and tricuspid valves visible. Interventricular septum must appear vertical and in the center of the image in a good 4 chambers view. Real-time images of the 4 chambers view are mandatory in any ultrasound cardiac study. You can appreciate in the image a right ventricle cavity dilated. Color Doppler is excellent because blood moves parallel to the ultrasound direction. Spectral Doppler is accurate for the same reason. The 4 chambers view is also very good for continuous Doppler. The image is a spectral Doppler of the mitral valve in 4 chambers. The view shows the characteristics 2 waves of atrioventricular valves. First wave occur immediately after mitral valve open, and the second wave with the atrial contraction. The 4 chambers view is very important in the study of mitral valve anatomy and pathology. Mitral stenosis, mitral regurgitation are the most common, but not the only ones. Anterior 2, or A2 and posterior 2 or P2 are the segments of the mitral valve that this view shows. Essential medical information in the study of mitral valve emanates from use of color Doppler and spectral Doppler. In the case the image is a large-scale mitral regurgitation. The 4 chambers view is also good and accurate for Doppler and 2D images of the tricuspid valve. Remember that the other view to observe the interatrial septum is the parasternal short axis or Mercedes-Benz view. Interatrial defects as the persistence of the foramen oval are congenital pathologies of the hearth commonly associated with others heart congenital diseases. The image is a pulmonary vein Doppler. Pulmonary veins Doppler is not part of regular echocardiographic protocols. 4 chambers view have multiples and special uses, depending of particular situations and patients. One of them is the calculation of hearth cavity volumes. Walls of the left ventricle are good displayed in the 4 chambers view, but the longitudinal direction of the ultrasound is not the best for B mode. There are a lot of applications to measure ventricular volumes. Some of them use the 4 chambers view, others more advanced use 3D and 4D. Four chambers view as other echo views are good to see pericardium, but 4 chambers view is very suitable to pericardiocentesis.
Lateral decubitus position if possible. Place the transducer at the apex or point of maximum impulse with the orientation marker to the patient's left side at a 3 o'clock position. The apex of the heart is visualized closest to the transducer. Move between the apical and peristernal long axis views of the heart to determine the most superficial and largest pocket of fluid. The myocardium will appear gray, and the blood-filled chambers will appear hypoechoic. The ventricles are in the near field, and the atria are in the far field of the image. A pericardial effusion will appear as a dark anechoic fluid collection.
5 chambers view is similar as 4 chambers view with the aorta, the aortic valve, and the left outflow tract. 5 chambers view is similar as 4 chambers view with the aorta, the aortic valve, and the left outflow tract. With the exception of the pulmonary valve, all the cardiac structures in the table can be seen in 5 chambers view. From the apical 4-chamber view, tilt the probe more superficial until you can see the aorta. The angle of the transducer and the thorax is a little more superficial in 5 chambers view. As you can see in the 2 illustrations, the angle of the plane used in 4 chambers view is deeper than the angle of the plane used in 5-chamber view. You can note the slight difference between 4 chambers and 5 chambers views. As can be seen on the images, the difference between 4 chambers and 5 chambers is the presence of the aorta and LVOT. Calcification of the aortic valve are easy to diagnose with 2D images in this view. Five chambers view is the best for spectral Doppler of the aortic valve. Aortic valve is a very important cardiac structure with a dangerous pathologies that need a early diagnosis because of multiple bad consequences. 2 chambers view is an accessory view, but provides additional information about the anatomy and function of the left chambers. Although usually the spectral Doppler mitral valve is made in view of the 4 chambers, may also optionally be taken in this view. Left atrium, left ventricle, mitral valve, pericardium are the cardiac structures in this table that can be seen in 2 chambers view. From the 4 chambers view, rotate the transducer 90 degrees until right cavities are not more in the image.
Let me switch over to the 2-chamber view. Quite often, one wall or the other will be difficult to see. We want to make sure we're seeing them both well, and in that case you may need to just change your position on the chest, change your angle a little bit. Often it's the inferior wall that is well seen and the anterior wall is not so well seen. As we can see here, it's falling out. So by doing a circle survey, I may be able to stumble into a nicer view of that anterior wall. Now look at my hand. If you notice, the heart is pointing off to the side. If I adjust my transducer parallel to the beam coming out, or the wedge coming out of my probe, you can see how that affects the transducer moving across the screen. So in this case, I'm going to need to move down a little bit the tail of the transducer to make my ventricle more vertical on the screen. And again, let's look at the apex here. This is a nice shot of the apex pinching off. If I'm adjusted a little bit, just ever so slightly, look at the apex now. It is actually squeezing in like if it was a short axis view. That means I'm foreshortening my apical view. So you need to make sure you've got that opened up all the way. In every apical view, you want to see it more pinching than just squeezing in. Now, if this is a difficult view, it's often very helpful to go ahead and rotate all the way to see the aorta come in. Now we know we've over-rotated for the two-chamber, and if we rotate back a little bit or twist back a little bit, now we know this has got to be the right place. If I'm under-rotated, then I'm going to see the right ventricle coming in. So this is under-rotated, and this is over-rotated. So you just want to be right in the middle. No RV, no AO. And now we know we've got a good apical two-chamber view. And in this case, we've got a really nice apex. One of the things you can adjust as well, as you can see here, this is our focus. So if I move my focus, if I'm not seeing the apex well, I can move my focus towards the apex and then often increase the gain a little bit, and now it may be a little bit easier to see exactly where that apex is.
The right cavities must not be in this view. Two chambers view is good for Doppler because blood moves perpendicular to the ultrasound direction. Real-time recording is the best option for 2D mode in this view. For specific pathologies of the left chambers or mitral valve, it is possible that the color Doppler and spectral Doppler are better in this view than the four chambers view. Apical two chambers view is a different point of view of the left ventricle, the left atrium, and the mitral valve. Mitral valve appears in a different orientation in this view, and different areas of the valve can be observed. Color flow and Doppler measures are possible in this view, but apical four chambers is more used. Left atrial appendage is a part of the left atrium where commonly, in the presence of cardiac arrhythmias, produce dangerous clots. Diseases of the coronary sinus are generally of congenital nature. His observation is not part of the most common cardiac ultrasound protocols. Apical three chambers view is similar to apical two chambers view, with the addition of the aorta. Left atrium, left ventricle, aortic valve, mitral valve, pericardium are the cardiac structures of the table that you can see in the three chambers view. To find the view, rotate more the transducer until aorta appears in the right side of the image. Optimal image contains left ventricle, mitral valve, left atrium, left ventricular outflow tract, and aortic valve. 2D real-time recording of this view can add more information to the study and can also be a good alternative when aortic Doppler was not satisfactory in the five chambers view. Doppler of the mitral and the aortic valves are excellent in this view, but are more commonly recorded from the four chambers view or the five chambers view. Three chambers view is excellent to observe the apex of the hearth. If you observe the three chambers view is very similar to the parasternal long axis view, but in different directions, and perhaps for this, the two aortic cups that are in the three chambers are the same that are in the plaques view. The critical velocity of the blood in aortic stenosis can also be recorded in this view. The mitral valve areas in this view are the same as parasternal long axis view. Three chambers view is an alternative view when other views do not give enough information. Left atrium is other structure that can be observed in three chambers view.